So I'm sure all of us have somewhere in our life reached this time where we were at the crossroads. For me, it was when I got this topic, when I had to think of what I'm gonna say when I have to speak on the indications of aqueous in the vitreous biopsy. So before I begin that, let me express my gratitude to Dr. SS and AIOS for giving me the opportunity to speak. And let me now address the elephant in this room. So let me do that with the help of the 4 questions. First is, when should I tap? Second is, which one to tap? And the last would be, which investigation you should be asking when you are tapping. So the first question is, when should I tap? And the answer is that there are 3 indications that you can think of when you want to tap the patient. First would be when you are seeing a typical presentation. Second would be when you are seeing an atypical presentation. And third would be when you see an inadequate response to the treatment. Now, let me tell you that typical presentation means when it follows a pattern. So in that, if you want to confirm the diagnosis, that's the time then when you would like to tap your patient. Atypical presentation is when it is not following the pattern, and inadequate response to treatment, I'll be showing you. So pattern recognition means when, with the help of the certain clinical features and your clinical acumen, when it kind of matches a certain pattern, it helps you in deriving to a clinical diagnosis. So for example, in this case here, we can see in this fundus photograph, there are these necrotizing retinitis with multiple hemorrhages. We can see hard exit, we see the optic disc is obscured. So with this pizza-by appearance, it's like a no-brainer. You will think that's a CMV retinitis. Of course, it's CMV retinitis. So that was pattern recognition. When you look into this fundus photograph and you see this unifocal necrotizing retinitis at posterior pole, you see the presence of this beautiful chirales all along. So here the diagnosis of toxoplasmosis is right in the hand. And third would be when you see this ground glass-like appearance and the presence of these multiple miliary lesions. So based on this, you'll think of the syphilitic chorioretinitis. So based on certain clinical features, and when it kind of matches a pattern and you come to a diagnosis, that is typical presentation when you are able to identify the pattern recognition. But suppose you see a case like this. For example, here, this is like a clover leaf kind of a pattern, and there is a presence of a retinitis here. So you don't know what you're dealing with. Similarly, in this case here, you are seeing that below the vessel, there is yellowish necrotizing kind of a lesion here, and there is a presence of this central clearing here. So again, these would be the cases where you would want to tap because you would want to know that what you are dealing with. Now, let me address the third indication for when do you want to tap would be when you see an inadequate response to the therapy. So for example, this gentleman who presented with this fibrinous anterior uveitis who was treated with the topical steroids, when on third day, he developed this large fibrin here, which is kind of obscuring the pupillary axis. And you can see the presence of a hypopyon. So here, the diagnosis was revised to the endogenous endophthalmitis. Now, this was a time then you would want to tap your patient. So I have told you that the 3 indications where you would want to tap. Now let me take you through the second question, which is which one to tap. You have 2 options, aqueous or vitreous. So logical thinking would be that you would tap the area where the site of the infective foci is max so that you'll get a better yield. So let's take this question that when you should be tapping the aqueous. So now take a look at this photograph. This is a case of an anterior uveitis patient who had this pigmented keratic precipitates. Now just let's reflect on this pearl for a moment, that when you see the pigmented keratic precipitates in an anterior uveitis, most likely you are dealing with a viral etiology. So here it could be either HSV or VZV or CMV. So here, if you're wondering that which viral virus it is, you would want to tap, and then you would tap the aqueous. And again, one more important point here, that provided the vitreous is absolutely clear and there is no lesion in the retina. That means when you are sure that you're dealing with only with the anterior segment presentation, which is anterior uveitis with pigmented KP. Now you all must be remembering, I took this example where this patient who was presented with fibrinous anterior uveitis developed endogenous endophthalmitis because we could see the hypopyon and this fibrin and stuff. So here this patient also had vitritis, and the B scan showed the presence of this lot of membranous echoes. So that's the point where we thought and we would think of going to the vitreous for the root. Now again, so when you see the keratic precipitates in a setting of an anterior uveitis, so the aqueous PCR is the way to go, which has a sensitivity and a specificity of 72.7% and 78.3%. Now, we know the indications. Now we know which are the conditions when you want to tap the aqueous. Now let's take a look when you want to tap the vitreous. So this is a case of a 38-year-old gentleman who was a diabetic patient and was recently COVID recovered. And he presented to us with the complaints of diminution of vision, which was counting finger close to face. And here you can see this yellowish retinitis lesion, chorioretinitis lesion here. You can see the presence of this telangiectasia. There's a lot of fluid around, and you can see the slight dilatation at the superior-temporal arcade. And if you do the corresponding OCT, you can see that though the retinitis is there, it's kind of popping up out in the vitreous, which is kind of a rain cloud-like sign. And at this point in time, this OCT would tell you that if you do the posterior vitreous biopsy right at this site, the yield would be better for you. So this is a case where you would want to do the vitreous biopsy. Now let me take you through the another example. Now here you're seeing this large retinitis lesion, which is going right up, and you see this disc is involved and you don't know what it is. I mean, this was a case of an ocular toxoplasmosis, but the caveat here is that in atypical presentation of toxoplasmosis, immune status of the patient is of paramount importance, because though we know that Goldman-Whitwer coefficient is the gold standard, but it is sensitive only in the immunocompetent patient. The reason why we keep seeing the various kind of the PCR profile is because not one DNA is analyzed. So that's the reason why in immunocompromised patient, the PCR yield through vitreous is better. Again, this is a case of a choroidal metastasis patient where the transvitreal biopsy was done. The indication is just that it gives you a better yield of about 85 to 97%. Coming to the last case, which is of an intraocular lymphoma, here you would want to do the vitreous biopsy because you want to look at the interleukin 10 and 11, and you look at the vitreous specimens. Now, the one important point here is that you would want to do this culture and PCR for a diluted specimen, and for undiluted, you want to do the cytology and immunohistochemistry. Again, another very important point that if the CSF biopsy confirms the lymphoma, you need not do the vitreous biopsy. So now you know the indications. Now you know which one you want to tap. Now let's come to the investigation you should ask for. So based on your relevant clinical history, based on your sharp clinical acumen and your first to differential, in an endophthalmitis patient, you would want vitreous. For pigmented KPs, you would want to do the PCR. For lymphoma, you want to do immunohistochemistry.
Sorry to interrupt, ma'am.
And I leave you with this question, that what if the labs result give you a different analysis in terms of your differential diagnosis and gives you a negative result? Thank you. And I would like to invite you to this meeting.